Today we've been dispatched to a young 20-year-old male who was doing a wheeling on his bike when he came off. His friend called the ambulance and it was a witnessed accident. On arrival, my patient is in a supine position. His helmet's still on. I don't see any hemorrhaging. When I greet him and introduce myself, his eyes are open spontaneously and he greets me correctly. I've introduced myself. He's responded. What's your name?
Justin.
Justin. What happened today, Justin?
Fell off.
Fell off. Do you remember falling?
Yeah.
No? Okay, you don't remember falling. Do you remember how we got here?
Yeah. I was riding here.
Yep. And what were you doing before this?
Before riding?
Yep.
Getting laps.
So this was a witnessed fall. It was witnessed that he hit his head. He is talking to me in full, complete sentences, indicating that he's got a good airway. His breathing is fine and his circulation looks good. I can see that he's well perfused. There's no cyanosis anywhere. I do trauma sweep to check for any quick injuries, see if I'm going to find anything like that. Because he's wearing a helmet, I would get my offsider to stabilize the head while I remove the helmet. I can now examine my patient's helmet for any injuries to indicate what part of the head might be damaged, if any. Now I'm going to start my rapid trauma sweep. I'm going to be placing my hand over you and asking if there's any pain anywhere. Is that alright?
Yeah.
So I'm going to start by checking the cranium, going around the back, round to the C-spine, checking my gloves for blood regularly. Now I'm going to check the C-spine. Is there any pain there? No, I'm going to go around the back to the scapula as best I can. I'm going to go down each arm. Any pain? No. I'm checking for any potential broken ribs or bones. I'm going to go along the clavicles. Any pain? No. Right. I'm going to ask you to take a big, deep breath in and out. Does that hurt?
Yeah, a little bit.
A little bit? Where does it hurt? Okay, right. That was equal air entry on both sides, indicating, because there is pain, that's indicating that there may be a problem, so I will come back and auscultate, but for now I'm going to continue my sweep. Now I'm going to do a quick respiratory assessment. I'm going to just unzip your jackets if that's alright. Cool. I'm going to expose the chest so I can look, listen and feel and auscultate and percuss. So again, I'm going to go here again. Can you take another deep breath in and out? Cool. And you see that hurts on your left side? Whereabouts? So I'm going to move down. Tell me where it hurts.
Yeah.
There? Okay, so on the lower ribs. Okay, I'm going to put my hands on your chest. Deep breath in and out again. Cool. So there's really good air entry. He's still able to talk in full sentences. When I put my hands on my chest, my thumbs move apart equally, indicating that there's equal bilateral air entry. Currently, because his vitals are normal and he's still saturating well, his blood pressure is normal, his heart rate's in normal ranges. I'm not worried about tension pneumothorax or hemoneurophorax or pneumothorax, any of the pneumothoraxes. I don't see any tracheal deviation, which would indicate pneumothorax. Currently, I'm not worried about any lung injuries. He may have a potential rib fracture. Is there any pain now, just when you're resting? A little bit. On a scale of 1 to 10, 10 being the worst pain you've ever felt, 1 being nothing, what would you rate your pain at?
4.
About a 4? Okay. So this is mild to moderate pain, so I would give him oral paracetamol and ibuprofen. If it got worse, that would indicate the use of methoxy, which is a fast-acting inhaled pain relief. Currently, I give my patient about a status 3. I would have cut off my patient's jacket so I could properly assess what's going on. I'm going to start by assessing his spine and the associating nerves. Right, so I'm going to just have a feel of your C-spine again, if that's alright. Is there any pain? No? Any altered sensation anywhere? And if I do this, does this feel normal? Does that feel normal? And On both your legs, does that feel normal?
Yeah.
Any numbness or tingling anywhere? Okay. Right, I'm just going to check my patient's medical history, or if he's got any known drug allergies. Do you have any known drug allergies? No? Great. And have you had a head injury before? No. And have you felt this confused before for any reason? Cool. Just to clarify here, I let my patient sit up because I'd clinically cleared his C-spine and I decided that there was no neurological or sensory deficit in his spine. There was no altered sensation and he had good motor tone as well in all of his limbs. If I did notice any neurological changes, I would have done a log roll, as I will discuss later, to assess any changes in the spine and palpitation, and I would have treated from there. Then, if I did find any abnormalities, I would have immobilized my patient as to not worsen any potential injuries he may have. Any neurological deficit could be temporary or could get worse with swelling or further movement of where the injury could be, as this could result in permanent damage in the spinal cord. On immediate arrival at the scene, I could see that it was a well-controlled scene. Everyone was calm. My patient didn't appear to be distressed. I could see that he was immediately presenting relatively okay. He was on his back. He hadn't gotten up yet. He didn't appear to be short of breath. I couldn't see any clear cyanosis or any increased work of breathing, any large losses of blood, any deformities or asymmetry within my whole patient's body that could indicate a major traumatic injury. If my patient at all started showing signs of neurogenic shock or respiratory distress, I would immediately call for backup, as my patient, due to the potential injuries he could have suffered, is vulnerable to decreasing in his wellness. He could become time critical. As my own patient was presenting, I was comfortable that he wasn't likely to deteriorate. He was only a little bit confused. He was still talking fully, he was responding correctly and not being too slow to respond and process my questions. He was able to obey commands. There was no altered sensation anywhere or control of his body. As I clinically cleared his C-spine and I didn't find any neurological or motor deficit or sensory deficit in my patient's spine or extremities, I decided that it was okay for him to move. If I did find any abnormalities in his neurology around his spinal area, I would have done a log roll with other people to assess his spine. I would have assessed for tenderness, irregularities and other abnormalities that I wouldn't normally find. Due to my patient's general presentation, his vitals, the mechanism of injury, my assessment of his respiratory system and neurological system, I was happy to conclude that he wasn't time critical, that he was stable. Oral analgesia was sufficient to manage his rib pain. However, I would have deemed it important to be constantly monitoring my patient on the way to hospital. He has shown a red flag that would deem transport to hospital. He's had a head injury. He's got a reduced GCS, which is a red flag, which indicates that I do need to bring him to hospital. He also had some amnesia, as he did not remember his fall, which is important. It's also another red flag. So, multiple reasons to bring him to hospital. Things that I could be worried about developing over time is a bleed on the brain, a worsening of his concussion symptoms, or a decrease in his respiratory efforts due to either pain because of the ribs. There could be a fragment of the ribs which could cause a pneumothorax, or there could be a hemothorax developing slowly. I'm going to check the actual procedures for checking the C-spine, because once I can clinically clear your C-spine, I can let you move.
Yeah, no, quickly quick.
Focus, please. Please? No. Focus.